Our first session that we're kicking off with is Next Steps for Primary Care. Primary care, of course, incredibly important to the public. 17 million people are now able to access GP appointments during evenings and weekends. This session is about what we are doing to fulfill the general practice forward view. And we will be using Glisser on this one. So again, if you want to ask a question, go to Glisser, Day 1, Innovate, and select this session. I'm going to introduce the panel. We have Robert Varnam, Director of Primary Care Development, NHS England, Arvind Madan, Director of Primary Care, NHS England, Vish Ratnasuriya, the Chair of Our Health Birmingham, Jeremy Taylor, the Chief Executive of National Voices, and Jonty Heaversedge, GP and contributor to BBC One's Street Doctor. So I'm going to hand over to Robert Varnam.
Thank you very much indeed, Jenny, and good morning, everyone. So my name is Robert Varnam. I am a GP about 2 miles that way, and I'm Director of General Practice Development at NHS England, which means I'm heavily involved at the forefront of NHS England's work to help general practice with OD and with leadership development. We're going to hear a bit more about some of the stuff that we're doing. But I'm here to mostly set the scene, really, for those of us who may not know all that much about what's happening in primary care in England at the moment. As Jenny was saying, primary care is at the heart of the NHS. It's the most used bit of the NHS. At least 90% of people's contacts with the NHS occur not in hospital, but out in the community in primary care. About 1 million people will have contact with their GP practice today. Internationally, it's one of the bits of the NHS that is most unique and most generates the most interest from people seeking to learn from the NHS. But you can't have missed the fact that general practice, like many parts of the NHS, is under huge pressure right now. And some of the pressure in general practice is actually unique and is quite significant and doesn't necessarily reach the same kind of level of media attention as, say, A&E departments. But the pressures are very real. So, for example, in the last 5 years in general practice, we've seen the number of consultations rise by 20%. But the number of GPs rise by 4%. We've seen the demands and the expectations and the things that could be done in primary care go up year on year on year. The things we'd like to see primary care doing go up year on year. But neither the funding nor the growth in the workforce until recently have in any way kept pace with the growth in expectations and the growth in the possibility. So there's a perfect storm of pressure on primary care right now. But there's another story as well, which is there's an amazing world of innovation happening in primary care right now. And that too has been building in certain pockets around England for a number of years. We're going to hear some amazing examples of it in this session. And so we come at an amazing time for primary care, where whether you're talking about the glass half empty view and you're talking about the pressures on general practice in particular, or you're talking about some of the innovation and some of the possibilities for the future, change is everywhere. And we're going to be hearing a lot about change, what's happening in change, what's happening to accelerate and spread innovation during this session. And I'd like to just tell you about something we're going to do using this Glisser opportunity. So if you've got a mobile phone, I'd be really grateful if you could pick it out. And we're going to ask you 2 questions. This is partly to make sure the system's working for you, but actually because our speakers would really like to know the answer to these 2 questions we're going to ask. The first one is, how involved are you in general practice? So people on the stage know an awful lot about what's happening right now and are involved in it, but we'd like to know how kind of much detail to give for you. So there are 4 options you'll see. I work in general practice, I commission or support it, I work alongside it, or none of the above. So only 4 options, quite easy. And just to remind you to go to glsr.it/innovate1. That gives you this session in this room. It'll ask you those questions. During the course of presentations from colleagues, you're going to have the chance to ask questions and to pose comments. And that's a much easier way in this particular format than running around with microphones asking questions and things. We'd really like to hear from you. So if you log into this system now, it will be really beneficial for all of us. if that's possible. So I'm going to ask if we can see, please, the result of that first question. Here we are. So 11% of people here work in, fifth commission or support, a quarter work alongside, and just under half of us none of the above. So that's really helpful. Thank you so much. We're going to have the next question now, which will update on your screen, which is this. How much do you know about the General Practice Forward View? So this was a huge program of policy and funding and OD and innovation support that was launched by the NHS back in April last year. Some of us in the room, we expect, know quite a lot about it. It would be helpful to get the detail from you about yourself, how much you know about it. So again, if you could answer just 4 options. Do you know it very well, fairly well, not at all? That would be really helpful. I'll give a few more moments, and then I'm going to ask if we can see the results of this question, please. So a pretty broad spread. Most of us at least know something about what's happening right now, which is really useful for us. Thank you so much for answering that question. So we're going to move on. We're going to hear in brief from 4 people involved at the forefront of helping primary care to survive and to transform for the future. Each is going to present some slides, talk for just 4 or 5 minutes. I will be helping us keep to time, because then what we're really interested in is kind of hearing your questions on the polling as we go through, and having a kind of a chat amongst ourselves about what we think about the challenges that you raise to us. So we want you to have your say all the way through this. So I'm going to begin by asking Jeremy Taylor, who's the Chief Executive of National Voices, to come and start us off from the patient's perspective. We're going to start with a patient's perspective this morning. Jeremy.
Great, thank you, Robert. Can people hear me? I haven't got any slides. I don't need to stand up, but I can stand up. I will stand up, actually. Yes. Yes, okay, good. Will multiple microphones create feedback? I'll take that risk. So my job in this, I think, is just briefly to ground the conversation and what actually matters to patients and people who use services. National Voices is a charity, an umbrella of charities, which advocates for person-centered care and for the role of people and communities and the voluntary sector as part of that. So that will give you a clue as to where we're coming from. So my first thought is that when we talk about primary care, we're actually talking about primary clinical care. And the real primary care is the care that people provide for themselves and each other as patients, as carers, as family members, and as members of communities. And as long as we lose sight of the fact that most of the care takes place in the community, I think general practice will continue to struggle to meet ever-rising demand. So for us, a really important part of redesigning general practice and primary care is to ensure that it is a service that supports people to do care for themselves. And I think it's inching its way towards that, but there's a long way to go. So when I was briefed for this session, I was asked to say something about what are the asks from patients to primary care and what are the asks of patients. From the system to patients. So I've just got a few thoughts. The asks of patients, and none of this is rocket science. Can I get an appointment? Will I have enough time when I get to see a doctor? Will I get the help I need? Will you listen to me? Will you explain things? Will you involve me? Will I get a joined up service? Will you help me manage? And actually, in parenthesis, would you let me do more online and digitally? Because there's a long way to go there. I'm also going to give you a perspective from what I would call patient champions, people working in the system alongside general practice and primary care, in Health Watch, in the voluntary sector, patient activists and patient leaders. They would ask all those questions of the services, but they'd ask a few more, I think. They'd ask, are you going to focus as you design and improve your services on what really matters to people and what they really value? Because what really matters to people in their health and what they really value is not always the same as what the NHS is providing. And it's not always what the NHS measures in terms of its successes. Will you make sure it works for everyone? So are you doing what you need to do to get your arms around the diversity in your communities and health inequalities and work to narrow those inequalities? Or are your service improvements and reforms unwittingly reinforcing a good service for those who already have a good service and leaving other people at the margin? Will you help people take more control so they can do more for themselves and each other and be less dependent on expensive, often disenabling interventions? And will you work with us, because we've got lots of capacity to bring to the party, lots of help and advice and support and volunteering and social action and insight that we can bring to the service improvement endeavour. And then finally, the asks of patients from the system. That's often couched in a negative way. We could run this system so much better if we didn't have these bloody patients getting in the way. So I'm going to ask some different questions. Will you let us have better conversations with you? Are you up for that? Conversations in which we're partners, not us on a pedestal telling you what to do as clinicians. Will you let us do more to help yourselves? We'd like to help you help yourselves. Not self-care in the sense of we're going to dump on you and get you to do more for yourselves because we can't afford to look after you anymore, but a partnership to enable you to do more for yourselves. Will you allow us to bring a team around you of different clinicians and workers and professionals, including you as a member of that team, to deliver really good joined-up care that works for you? Will you let us share your data with the right caveats and protections applied? And will you all help us to get this right, because we as clinicians can't do this on our own? So I hope that I've given you a little bit of a framing around what matters to patients and how we can be involved in the process of getting primary care right, which is primarily what happens outside the surgery, but also to help primary care as a clinical endeavour be improved through our involvement, and to get general practice right, which is part of that. We haven't got enough time to debate the distinctions between general practice and primary medical services and how they joined up with community services. That's a really important part of it too. So that's enough for me. Thank you very much.
Thank you for that. Just a reminder, if any of that stimulates a question in your mind that you think you want answering, you can not just submit that question on Glisser, but you can also vote on the other questions that are coming in from other people. So we'll see kind of where the interest is, because I think some really helpful issues raised there. I'm going to hand over now to Dr Arvind Madan. Let him introduce himself and talk about what's happening from his perspective.
Thank you, Robert. I'm Arvind Madan. I'm a GP. I've been a GP 20 years. I'm a partner in a group practice in London, but 4 days a week I'm Director of Primary Care for NHS England as of the last 18 months. And we're now 18 months through the General Practice Forward View, which was launched in April of last year. And the General Practice Forward View is a 5-year strategy to try and stabilise general practice and transform it for the future. And actually, it's got 82 different initiatives in, and what started with a relatively small group of people working across a number of organisations, including the Royal College of GPs and the BMA and others, including patient groups, it's now turned into a bit of a movement across the country involving hundreds of people in its delivery. But what I thought I'd do in the short time I have is try and give you a sense of the progress that's been made and reminder of what life was like beforehand, and some of the sort of criticisms that we've faced and you know, in some respects fairly continue to face in some corners. So one of them is around the General Practice Forward View is not funding general practice sufficiently. Well, the General Practice Forward View includes a plan to increase funding in general practice on a recurrent basis by 2.4 billion extra per annum by 2021. Now, it's worth kind of just teasing that apart a little bit. That's a 14% real terms increase over the next 5 years, and that's in comparison to an 8% increase for the rest of the NHS. There are specific elements of that in terms of the contribution from CCGs, the £3 a head over which we're trying to gain complete reassurance across all the CCGs at the moment. The global sum increase in the general practice contract, the move away from micro incentives and putting more money into things like frailty as opposed to unplanned admissions, enhanced services, and actually help with some of the wicked problems of general practice, at least in the shorter term, until we come up with longer term solutions to issues such as the rising cost of medical indemnity. NHS England isn't doing anything about the workforce crisis. Well, we know we have ambitious targets, around 5,000 additional GPs by 2021, and there are a number of things happening to try and get us to a self-sustaining position over our general practice workforce ultimately, such as the increase in the number of places in medical schools, 500 next year and an additional 1,000 a year, the year after, taking us from 6,000 to 7,500 places a year. Increases in the number of GP training places, 3,250 places per annum, and we haven't quite filled them, but we're north of 3,000, which is meaning that we've got the highest numbers of GPs in training than ever before. And the early indications this year is that we're 5% up on last year so far. There are enticements not only to bring more doctors into the system, but how we distribute them. So for example, the salary supplement schemes for doctors working in under-doctored areas, the post-CCT fellowships, improvements to the induction and refresher program with financial payments so that doctors can sustain their own household incomes while they're going through this phase, but also hand-holding support on an individual basis to help them jump the obstacle course that is the return to work process of old. Probably the thing you've heard most about is the international recruitment program, where we're looking to bring in 2,000 to 3,000 doctors from abroad, but actually not just bring them in, but actually help them settle. So akin to the schemes that we've had in places like Lincolnshire and Essex, where we give them 3 months induction on what working in the NHS is going to feel like. Pair them up with practices where they have employment, help for their spouses to find employment, help for their children to get into local schools, and connect them with local communities from the same origin. We're doing things around the GP Career Plus scheme to try and dissuade doctors from retiring early. The two issues that are challenging the general practice workforce numbers are doctors retiring early. The attrition rate is higher than previous expectations. And the level of participation of GPs, so the amount of part-timeness in the profession, because actually, frankly, which I'll go on to, workload is our major challenge. There are also things around the GP health program where we've had 500 doctors gain support for mental health and addiction issues from around the country over the course of that service, which is January of this year. But we're also making progress, and we've probably we're halfway through the 5,000 target that we set ourselves in relation to other professionals working in primary care, improving how we support the nursing workforce, the practice managers' development, the clinical pharmacists, 500 in place and another 500 improved, with a target of ultimately an extra 1,500 by the end of the general practice forward view. Physician associates being trained at the moment, mental health therapists, of which we hope there will be 3,000 based in primary care by the end of the program, as well as upskilling existing staff within practices. In terms of the workload, which is possibly one of our biggest challenges, lots of things happening here around self-care, and I'd like to go back to Jeremy's points, but we'll see how the discussion unfolds. Self-care, community pharmacy, social prescribing, and direct access services such as open access physiotherapy are gathering pace, so that some of the musculoskeletal problems that are currently taking up time in general practice can go straight to a physiotherapist in some health communities. Changes to the 111 service, changes to the rollout of how we're going to do access hubs, so the whole country is covered, not just the 17 million that are currently covered by March 2019. The Practice Resilience Programme, which has put £27 million into practices to help stabilise the situation, the Time for Care programme, which I'm sure Robert would like to talk about, which is the largest organisational development programme in primary care anywhere in the world ever. the work that's happening around socializing the changes in the standard contract. So we take a chunk out of the 16 million low-value appointments that relate to hospital episodes, where things could have been dealt with in a hospital interaction that end up back in general practice. And how we streamline data collection across the arm's length bodies, and how we improve the payment system, and how we've moved towards a lower frequency of CQC inspections in practices. A whole trend away from the sort of micro-incentive culture of the existing contractual mechanisms. I'm running out of time, so I won't say too much on the infrastructure element, but an 18% increase in IT support for general practice and primary care, and a whole pipeline of activities in relation to the Estates and Technology Transformation Fund. So what is this all going to look like in the future? If we bring all these bits of the jigsaw together, what is it going to feel like? Well, the five key enablers, I think, are around self-care, around skill mix, around working at scale, around how we use technology and how we align incentives across practices and secondary care. So how I would characterize where we are at the moment is the general practice forward view is a good start to addressing a decade of underfunding in an NHS, which has historically, due to the way in which we collect data, had an acute sector bias. And we're going to need to work together to actually get the best version of the general practice forward view possible. Some have said that it's hardest to know in the midst of large change in a system whether it's working or not. And sometimes it's only when you're sitting on the porch in your rocking chair some years later whether you recognize that that was an inflection point in the history of English general practice. And in my role, I get a constant stream through one ear of the end is nigh, general practice has gone past its breaking point, it can't be saved from here. And in the other ear, I get a constant stream of actually, we're starting to make some really significant changes, and actually we're on the road to recovery, and actually a different version of how general practice can play its role in the wider sustainability of the NHS. And I was recently asked to assess 59 applications for the General Practice Forward View Awards. And I was taken aback, and I saw beyond my cynicism, of course they're going to portray it well, they're trying to win an award here. But actually these were examples of large groups of practices taking on some of the changes that have been offered to them in the General Practice Forward View with evidence to back up the fact that it was starting to make a difference to patient experience, to health outcomes, to how the morale of the workforce was materially different, to value for money in the system. So I think for some, the jury's still out on whether the general practices forward view is working. 18 months through the program, I'd say we're in our teenage years, and this is when we find out what the character of the program's going to ultimately be. But what I would say is we're starting to see evidence that those who are early adopters of some of the menu of support that's available are starting to show progress and are on the road. Thank you.
Thanks very much, Arvind. Thank you too for all the questions that are coming in. Just a reminder that if you go on Glisser, you can ask a question as well as vote for the ones you'd most like to see featured in the discussion we're about to have. But now I'm going to ask, we're going to kind of shift perspective from the national policy perspective to a local experience of a clinical commissioning group and their work in helping to drive change in primary care. I'm going to ask Jonty Heaversedge to talk about his experience from Southwark.
Thank you, Robert. There you go.
I apologise. We have slides in the
There we go.
There we are.
We'll have to go backwards. That's fine. That's absolutely fine. Thank you very much indeed. Thank you for inviting me. It was nice of Jenny to introduce me as a presenter of Street Doctor, a previous career somewhat, but I'm also the chair of Southwark CCG, and I've just been appointed as a regional medical director in London for primary care transformation and digital, which we may get a chance to talk about a little bit more later. But really the opportunity this morning is to talk specifically about some of the work that we've been doing in Southwark. And really I wanted to begin by reiterating the value of primary care to the system, but importantly that key enabler that Arvind just talked about, which is working together at scale within general practice. We recognised this as being important in Southwark about 5 years ago for a number of reasons. A lot are obviously related to the kind of quality of care that we can deliver for our patients and our local population. But we also recognised the value to the system of primary care and why it's important to work collaboratively to deliver better value within the system. But also the opportunities that it creates to work together for staff, the workforce opportunities, the new opportunities for different sorts of career, and a lot of leadership opportunities that we've absolutely seen come to fruition across Southwark. There were legitimate concerns. Of course, there were about the loss of a more intimate and personal service, the continuity of care that patients receive, the connection with the local community, and that important sense of identity that people feel with general practice. So the secret to all of this, I think, is how we're going to be big and small at the same time. And importantly, actually, how being big can enable us to be better at being small. And that's the challenge, and I'm really interested in the conversation today because how we do that is going to be crucial. Importantly, from my point of view, general practice working collaboratively at scale isn't just about better general practice. It's essential to new models of care. It's essential to the way in which we deliver community-based care going forward. Our model of community-based care is called local care networks, and at the heart of that is general practice. But actually, as we've started to develop our federated model of general practice, we've been able to wrap around that community services, mental health services, our district nursing services, to really start to think about an integrated new model of care for the future. As I say, which has general practice as a building block for that. This is the picture in Southwark currently, and I guess on this slide I just wanted to flag a couple of important things. We recognised early on that we weren't going to specify a model of working collaboratively at scale in general practice, but we did realise that being inclusive and population-focused was essential. So we've had 2 federations that have emerged, including all 38 practices in Southwark, one in the north of the borough, one in the south. And that's been important because actually it also reflects a lot of the other parts of our health economy. We've got an acute trust in the north and the south. We've got community services geographically aligned in that way. And actually our social care increasingly is aligned across the borough in exactly that way. The practices began by doing things together, and I think this again is a message that I want to get across very strongly. So we started, of course, with some seed funding through what was at the time the Prime Minister's Challenge Fund to deliver extended primary care services 8 till 8 to the population across Southwark. That gave practices a chance to start working together. We've been able to build on that, and over the last couple of years, not just deliver services collaboratively, but actually look at how we improve the quality of those services together with, for example, the 10 high-impact actions that I'm sure Robert will be happy to talk further about. And most recently, we've moved to think about how we integrate now with our acute trusts and other organisations within the community. And we've started to think about how we can support people with 3 or more long-term conditions. Again, recognising that it's usually by trying to do something together that partnerships develop and relationships are created. So that's absolutely at the heart of the care coordination pathways that our GP federations are leading as part of these new models of care. So finally, I did talk to the federations about the key opportunities that they feel they've managed to identify through this process. They talked about workforce, they talked about the opportunities there have been for new careers, for new opportunities for leaders in the South Federation. They've created a staff bank, which has been incredibly helpful in ensuring that we identify people to resource the additional capacity that we've created in general practice. There are efficiencies, and of course those relate to the back office, but actually you'll see on there an integrated care manager. An integrated care manager is a healthcare professional who is employed between the practices in a federation to deliver holistic health assessments as part of that coordinated care pathway that I just showed you, because we recognise that individual practices, particularly the smaller practices, didn't have the resource to be able to offer up all of those same opportunities to patients. We've been able to connect up and communicate with each other using information and technology. So our patient record system is now shared, and that's allowed for very different ways of working together. We've been able to look at creating better resilience, and that, of course, has been about delivering better quality. We've got a whole cohort of improvement leaders who've been able to roll out the 10 high-impact actions as part of the GP Forward View. And I think we've seen great resilience born out of partnership. The recognition that actually general practice is now leading the way with some pretty strong acute trusts, Guy's and St Thomas's and King's College Hospital and the South London and Maudsley, in delivering new models of care, I think is vital. The challenges, of course, are there for everyone, and they've already been alluded to. Robert mentioned them at the beginning. Fundamentally, trying to sustain this change is challenging, and particularly trying to sustain the change when the pressures of today are so great, and we've got to have this maintained focus on tomorrow. I hope that's a helpful brief introduction. Happy to join in the conversation afterwards.
Thank you very much indeed, John. So I'm going to ask Dr Vish Ratnasuriya from Birmingham now to talk about their work. Excuse us while we very quickly rearrange the slides. Vish, over to you.
Thanks, Robert. So good morning. My name is Dr Vish Ratnasuriya, GP at Lords of Medical Practice in Harborne, and I've been tasked to tell you a little bit about what the future may look like in general practice. You've had a subliminal view, so hopefully it feels a bit familiar. So Our Health Partnership is a single merged partnership or super partnership of 340,000 patients served by 186 partners and 920 staff across 45 sites. A single partnership, but critically not a single way of operating at practice level, so we can be locally responsive to our individual patient population's needs. When we began thinking about large-scale change, to give us, GPs as providers, a voice and influence within the health economy, gain efficiencies, but most of all, improve quality for our patients and practices, we realised that we needed a different model. A model that valued localism, but allowed us to act more corporately, together as one, under strong leadership and governance, to achieve our twin aims. So how did we do this? Well, we needed to create a bespoke deed where practices became profit centres. We call them constituent practices. Contracts are held locally, and this enshrines coalface autonomy. And for us, autonomy means responsibility and therefore quality. We're a ground-up organisation. We had no seed funding, so I believe, therefore, we're sustainable. We're growing both within our Birmingham and Solihull footprint, and we've also been joined by colleagues who share our ethos across Shropshire, so we're now active in the urban, suburban and rural environments. So whilst the business plan is, our business plan describes our many streams of transformation, I'm just going to focus on these few areas. Efficiencies. Well, these are the basics of working at scale and not the reason you should form around. We've got a single bank account system where individual practices retain their income and expenditure streams, single payroll, single finance system that allows us to interrogate a wealth of information. Live in-house accounting, the previous GP experience being buying them in, done in retrospect, variable quality and methodology. And procurement. We're reducing costs at each line by 10 to 15% and often much more, and this includes indemnity in partnership with MPS. So across the board, improving quality and reducing cost. Workforce. We've created an in-house GP bank in response to a 1.3 million locum spend pre-merger, so now patients get an improved quality of care and practices get better help with their ad hoc needs. We're developing a staff bank, and we've got various different recruitment and retention schemes, critically designed in response to listening to colleagues at the beginning, middle and end of their career, and this will result in new ways of working. We've created a virtual support team, expert GPs, nurses and managers who can help us in times of need, help us with quality issues, providing a menu of solutions, all whilst reducing risk and improving quality at an industrial scale with MPS. So we spent a couple of years building OHP as a platform. We're much greater than the sum of our individual parts. And we've done this in a considered way so that any patient-facing change is sustainable. If one were critiquing general practice at scale, you might say, what about the gaps? What about the practices between? And at OHP, we tried to address this. So alongside, I skipped a bit there. So alongside 300,000 patients worth of OHP practices, we've now working alongside neighbours and colleagues. We've set the right landscape to work in 6 localities. So our redesign will be based on the coalface. I've just skipped past one slide, so I'm going to go back to that. I apologise. So quality, this is really important. We've got a single GP corporate CQC registration where the board is now inspected and practices provide assurance feeds to the board. It's managed by a governance team, and practices are no longer inspected as an individual site, crucially retaining local accountability, and that's what patients look for and want. So back to our localities. Our redesign is going to be led from the coalface, alongside patients and colleagues from across secondary care and across the system, all working towards a single seamless NHS and care as close to home as possible. And we're soon looking to replicate this in Shropshire. The slide thing's not working there. There we go. Access and urgent care. Well, this needs to be part of any future system. From the outset, OHP have wanted to provide 24/7 general practice within the organisation. We started with whole-scale opting into out of hours, and we're just starting to work in to co-design with our local acutes the future urgent care system, provider to provider. Importantly, starting with the data and what patients need and what their behaviours show us. So watch this space. So that's us, Our Health Partnership, a ground-up organisation that preserves the best of local general practice whilst being able to act more corporately. We've enshrined coalface autonomy and leadership and the face of the local surgery that patients value, while OHP, GPs sit at the STP alongside trusts, doing the right thing for patients, the practices and the system. Thanks, Robert. Cheers.
So thank you very much indeed for that, colleagues, and thank you too for all the questions that you've been posing to us during the session. Just a reminder that Glisser will be operating throughout the conference as a way of interacting like this. We'd like to pick up some of those questions you've been asking us in conversation now with the panel. And I suppose there are three big questions I think come up all the way through, which I think have partly been addressed so far, but I'm going to see if what you kind of guys would like to say more about on some of them specifically. The first question has been from people saying, what does the future look like of primary care? It'd be interesting to ask you in a moment, like each of you to describe what you think it's going to be like for a patient, say in 5 years' time when they're accessing primary care. What's going to be different in particular? Second question is, a lot of people have been asking things along the lines of, really? Seriously? Is it real? Is it actually happening? And I think to some extent, what we've already heard has said, yeah. It's in pockets, it's in varying work streams. I think the rest of the conference is going to give a lot more intricate detail about how that looks. And then I think the third question is a lot of people saying, how? How do we sustain this? How do we spread it? And again, we'll close maybe with sort of a question to each of you about what you think we should do more to make that a reality. But let's kind of go back to this first question. A few people have been saying, so from the patient's perspective, what's going to be different in a few years' time for the patient accessing primary care? And I wonder, Arvind, if you could kind of give us sort of a little vignette of what you think some of the key differences are going to be. We'll see what other people think as well.
So I think we need to be conscious that most of the time people are well and they stop their lives to receive healthcare. And actually we want to make that disruption as minimal as possible to some degree. So we are a sort of diversion off their main road. And actually in that diversion, I think there's the opportunity to actually, alongside the sort of technology they might use as part of their day-to-day existence, like their Fitbits and their various other wearables and apps, etc., that go beyond sort of true healthcare and into sort of nutrition and diet and exercise and lifestyle. Actually, how might we start to think about, when they do feel unwell, wrap around the kind of opportunities that, 50 million hits to NHS choices every month. I mean, how do we start to take that kind of appetite for understanding the use of technology in that pathway? How do we start to build on the care navigation training that's happening around the country now, and in which we're investing 45 million over the next 3 years, so our reception teams are better placed to guide people and signpost them to other services around social prescribing, around community pharmacy, around minor ailment schemes, around how the third sector can support us, how we rewire that element of the pathway, how we wrap around the wide range of disciplines that we have within what I think will be a growing primary healthcare team, in the way we currently think of the practice nurse as an ordinary part of the team, and are increasingly thinking of the clinical pharmacist as an ordinary part of the team. Who else, what else could we be offering? And how might we filter the demands of patients and the needs of patients in a way that actually not only is a really great experience of care for them in the most convenient way possible, but actually also helps practices become more efficient, whether that's telephone or online triaging. And ultimately where I think we want to get to is have the right patient in front of the clinician at the right time, and ideally with more time than they're currently getting, than the 10-minute traditional consultation. And how do we connect those practices with other practices so we can wrap care around the whole week? And how do we wire in specialist remote support so patients aren't necessarily put on an outpatient pathway where we can source advice quite rapidly for them inside the practice with the specialists from the local trusts and wider community services.
So I'm conscious of the fact that we keep describing a massive package of change. You know, there's sort of everything from incremental innovations and improvements to huge transformational change here. And a lot of people are asking questions about how engaged people are and how do you persuade people. There's a lot of stuff about leadership at this conference. If you'd like to go to some, do pick some from the program. But Vish, you're at the heart of a group of GP practices who are already doing this. How have you made it happen? I mean, how have you persuaded GPs, practice nurses, practice managers, and the wider primary care team to go on this journey with you so far?
I think we started by listening to colleagues and valuing their opinion, and seeing how how using that we could find a way forward. We were very kind of considered and iterative in the way we did things. We consulted practices, localities, and built OHP in that way. So we keep refining and rethinking. We lead through arguments, persuasion, not diktat. We've inverted the pyramid in some ways so that we provide as much autonomy as we possibly can at the coalface, listen and co-design, and that's how we've approached things, and I hope that stands us in good stead.
That's really helpful, thank you. And Jonty, a lot of questions are coming up about whether all of this is a bit redundant. Now we're talking about accountable care organisations, accountable care systems, population focus and STPs. Does general practice just really not fit? Or it seems like in Southwark you're describing general practice being at the heart of all of that. How does that look? Is someone responsible for commissioning health outcomes for population?
From my perspective, it's so general practice. I think, as I said, is a kind of key building block to any. So we know that general practice is fundamental to us delivering better value. Better value, by which I mean better outcomes for patients at lower or the same cost. So if general practice is the part of the system that's going to help us deliver that, then really it doesn't matter whether we're talking about new models of care, MCPs, networks, hubs. Fundamentally, general practice has to be central to whatever our new vision is of accountable care. And of course, accountable care is about people taking shared responsibility for resource around a particular population. General practitioners know absolutely how to do that, and if they do that hand in hand with the local population, then I'm absolutely convinced we're going to start to see better value.
Thank you so much. We're going to allow ourselves 20 seconds final word to Jeremy Taylor from National Voices. On behalf of patients and community, a load of questions here about what the partnership looks like. Could you say what the offer could be from patients and the public themselves to be part of this journey? How could it look like for us to be doing that in partnership together?
There's a chap called David DeBroncart. He's an American patient activist. Who has written a book called Let Patients Help. The people have huge resources to help themselves, to help others, and to help the system. I think the NHS is at the foothills of a climb up towards the peaks of real co-production, and has barely started the journey. So the offer is there at all levels in the system, from national organisations like ours to tiny voluntary groups to patient participation groups. The resource is there. And I think there will never be enough doctors and nurses and healthcare professionals to sort out all the healthcare problems if we see it primarily as an enterprise that's done to people. We know that's true kind of morally. We also know that there's an increasing evidence base that supports that contention. So if it's about mobilizing all the resources, then take the offers of help that are already there, but also go out and try and get more help. So I think there's no limit to that, actually.
What a great place to finish. Thank you very much indeed.
go over here because I don't have one. Thank you very much, Robert, Jonty, Jeremy, Vish, and Arvind, for a session that I think could have gone on a lot longer. Thank you very much. Come on through.